Okay, thank you. So this was a task, a particular task that I asked to perform. So maybe I can ask one of the first group to say a few words about inflammatory bowel disease. May I ask you?
Yeah.
Speak up loud, please. And everything is okay, what you say.
Okay. So it is a chronic disease. It's caused by inflammation in the bowels, and there are two types of it, or so the ulcerative colitis, which is in the colon and the rectum, and Crohn disease, which is in the wrist. And I heard it's like a patchy.
Yeah, very good.
And you treat it with immunosuppressive treatment, so like anti-inflammatory or like these are things.
Okay, very good. Do you know people with Crohn's disease, friends or family members? 1, 2, 3, 4. That's a lot, actually, yeah. So it's a pretty highly prevalent disease, inflammatory bowel disease, and encompasses Crohn's disease and ulcerative colitis. I will tell you more about it. And we see here at the Amsterdam UMC the most severe cases, because it's a tertiary referral center. We have the largest outpatient clinic in the Netherlands for IBD, but we also see many patients with mild phenotypes, with mild disease. We see the quite severe cases. Okay, thank you for that summary. The second group, may I ask you to maybe say a few words about the old conventional drugs? Maybe the previous presenter told you about the old drugs. Can you say a few words?
So there's generally two different drugs that are used. First one is methotrexate, which was first used oncologically, but also as a treatment for rheumatoid arthritis and sometimes psoriasis. And it inhibits the JAK-STAT pathway, which causes immunosuppression. The other kind is thiopurines, and those act on the azathioprine metabolism, which then also causes immunosuppression. But they're used in different, clinical cases, so to say.
Okay, thank you for that summary. One remark: the methotrexate is a very old drug on the market since 60 years, 60, for various diseases. Hematological diseases, but also immune-mediated diseases. Think about rheumatoid arthritis, think about inflammatory bowel disease, but it does not act on the JAK-STAT pathway. I will go into the JAK-STAT pathway, but that's a pathway which is really important in immune cell activation, that is targeted by different agents, very new agents. I think the group on row on the how do you say, final row will tell you more about the anti-JAKs. But methotrexate and thiopurines, they share one common thing, and that's that they interfere with DNA synthesis. So they are anti-metabolites, and they mainly attack the T and B cells, and this results in decreased proliferation and apoptosis of these cells. But thank you very much for the summary. Then the anti-TNFs. Can you say something about anti-TNF? Yeah, please.
So TNF alpha is a pro-inflammatory cytokine, and using anti-prostaglandin, that cytokine you can inhibit the pro-inflammatory response, and that thereby decreasing inflammation.
Okay, very good. Very good summary. So TNF is I would say, hallmark cytokine, not only in inflammatory bowel disease, but also in other immune-mediated inflammatory diseases, such as, again, rheumatoid arthritis. Anti-TNFs are a game changer in the treatment of IBD and rheumatoid arthritis. So what they actually do is they neutralize the effect of TNF. TNF stands for tumor necrosis factor. Tumor is a bit of a strange terminology because it's not associated with tumors, it's associated with inflammation. But very good. So then the last two topics. Who wants to say something about the newest biologicals. You? Yeah, is it okay? Thank you.
Yeah, so you have the anti-integrin therapy.
Yeah.
Integrin is a cell-surface glycoprotein receptor responsible for leukocyte homing in the tissue.
Yeah.
And this is actually done by vedolizumab. It's an antibiotic that inhibits the binding of alpha-4 beta-7 integrins to METCAM1 and leads to the decrease in intestinal inflammation through inhibition of lymphocyte migration to the intestinal tissue.
Okay, very good. So that's a migration inhibitor. It prevents T and B cells to home to the intestines, so they stay in the blood, and in the blood they at a certain point die, as all immune cells do at a certain point. So this medicine blocks the migration of T and B cells going to the intestines. I will go into that deeper. One remark: it's not an antibiotic; it's an antibody. Yeah, okay. So very good. And is there one of your colleagues who wants to say a few words about interleukin inhibitors? Maybe anti-IL-12, anti-IL-23. Did you read about that molecule? A lot of pharma companies are investing on that mechanism at the moment. Yeah, please.
So they inhibit those, for example, the IL-23. It inhibits the IL-23 and it blocks T helper 17 differentiation.
Fantastic.
And it also prevents recruitment of inflammatory cells.
Yeah, fantastic. Very good. So I will go into that deeper as well. So, and then the last row, maybe a few words about the newest small molecules. Who wants to say a few words about that last topic? You?
Me?
Yeah?
Well, I wrote that the YAP inhibitors are supposed to inhibit multiple kinase pathways. Yeah, so that's multiple targets, but I don't know for the rest of it.
Okay. Yeah, but it's good. So the JAK inhibitors go into the cell where they do the job. So they are not antibodies that are too big to enter cells, though they act on the cell surface, they block a certain receptor or interactions between the receptor and a protein. But the JAKs, the anti-JAKs, are small molecules, synthetic molecules, made in the lab via biochemical formulation, and they go into the cell, and there they do the specific job. I will go into that deeper. Did you read about S1P receptor modulators? No? There were a few, I think. Sorry? Yeah?
Well, with the modulators, they cause a phenomenon that prevents the lymphocytes from moving in lymph nodes.
Very good. So it's a very smart drug. There are two agents on the market for ulcerative colitis, not for Crohn's. It's very interesting. They don't work for Crohn's disease. They only work for ulcerative colitis. And what these agents do is they really trap the T cells and the B cells in the lymph nodes, so they cannot enter the bloodstream. So they stay in the lymph nodes. In the first phase of the treatment, the lymph nodes become bigger. You can really sometimes feel the lymph nodes. Patients don't like that, but it's not related to lymphomas. In the lymph nodes, the T and B cells at a certain point die. So in the blood, you have low T and B cell counts, and that's the immunosuppressive effect. So you really lower the number of the T and B cells. That's a question.
Yeah, doesn't that give you a higher risk of any other diseases?
So not other diseases, but what do you think is the risk?
Well, if you don't have any T or B cells in your bloodstream, you cannot do an adaptive immune response.
Yeah, that's a very good question. But they are lowered, but they are kept above a certain threshold. So the immune function is still adequate. So if there is a bacterial infection, they can easily kill the bacteria, the pathogens. If it becomes problematic if there are no T and B cells, but that's not the case. There are enough T cells for a normal functioning immune system, but the number is lowered, so it is a certain immunosuppressive effect. So infections, that's actually the side effect, infections. So people are at a little higher risk of certain infections. Yeah.
In the article they make a distinguishment between non-selective and selective JAK inhibitors. And I was wondering what they select for. Is it just that selective JAK inhibitors only target one JAK?
Yeah. So the JAK family consists of 4 members. JAK1, JAK2, JAK3 and, very strange name, TYK2. I don't know why they came up with it. So these are the 4 members, and they play important different biological roles. For example, JAK2 is very important for erythrocyte formation. So to have enough hemoglobin in your blood and red blood cells. So if you block JAK2, you get an anemia. You get low erythrocytes. You don't like it because patients become fatigued and so on and so on. JAK1 and JAK3 are probably the most important players that you should inhibit, and maybe also TYK2, but JAK2 you would like to leave alone. So the selectivity is, the first agent that came on the market was tofacitinib, and it blocks JAK1 and JAK3. And then pharma companies thought maybe if you only target JAK1, it's more effective and maybe safer. And there's still a lot of debate if that's really the case. At the moment there are many different JAK inhibitors for different indications. For ulcerative colitis we have 3. We have the selective ones and the less selective ones. For Crohn's disease we have only 1, a JAK1 inhibitor. They all have their advantages and disadvantages. If there is time, I can show you. Does it answer your question? So it has to do with the target, the specific JAK isozyme. Okay, thank you for the